Hi, everybody. I'm Dr. Michael Richman, a double board certified cardiothoracic surgeon. In previous talks, I've spoken to you about various aspects in cancer diagnosis and cancer treatment, including talking about clinical trials. So today I want to talk to you about two endpoints in cancer trials that are often misunderstood by patients and doctors alike. In the landscape of cancer therapy, clinical trials, as we know, are pivotal in determining the effectiveness of new treatments. Two critical endpoints commonly assessed in these trials are first, progression-free survival, known as PFS, and overall survival, OS. Understanding the distinction between these two measures is vital for doctors, researchers, and patients alike, particularly when evaluating the efficacy or effectiveness of treatment. In layman's terms, they provide insights into the effectiveness of therapeutic interventions and inform treatment decisions. PFS refers to the length of time during and after treatment that a patient lives without the disease worsening. Essentially, it measures the time from the start of treatment until the disease progresses, and we assess that by increased tumor size, new tumor formation, or deterioration of the patient's condition, or until death from any cause. PFS focuses on the duration during which the disease is under control, which indicates the treatment's effectiveness in preventing disease advancement. In contrast, overall survival, or OS, is a more definitive endpoint, which measures the time from the diagnosis of cancer or the start of treatment until death from any cause, regardless of whether the disease has progressed. OS is arguably the most definitive endpoint in clinical trials. I'm sure it makes sense to you, as it directly reflects a patient's longevity and ultimate outcome following a particular treatment regimen. While progression-free survival can indicate how well a treatment is managing the disease, overall survival provides a holistic view of its impact on patient survival. So the differences in these endpoints can align closely with patient experiences and expectations. For patients undergoing treatment, especially for very aggressive or metastatic cancer, the desire to halt or slow disease progression can often be more immediate than concerns about long-term survival. Therefore, PFS can provide a more immediate indicator of a treatment's effect, showing how effective a therapy can be in staving off the progression of the disease. PFS, however, can be subject to measurement bias and wide variability. The validity of progression-free survival as an efficacy marker has been a topic of considerable debate. In many instances, achieving a significant increase in PFS is interpreted as an indication that a treatment is effective. Clinical trials that report improved PFS often generate excitement, suggesting that new drugs could provide added time before disease worsens, thus improving quality of life. For certain types of cancer, particularly those with slow progression rates or chronic types, an example of that would be chronic lymphocytic leukemia, prolonged PFS can correlate with improved patient outcomes. However, there are notable caveats to consider. The primary issue arises when PFS becomes the sole focus of treatment evaluation. You need to remember that an increase in PFS does not always translate to improved overall survival. A treatment could theoretically extend the duration before cancer progression occurs, but may not improve how long patients ultimately live due to factors such as adverse treatment effects, the potential for treatment-induced toxicity, or the lack of effective subsequent therapies once the disease progresses. For instance, in some clinical trials of targeted therapy, which we use for actionable mutations, PFS may improve significantly survival, but if patients endure severe side effects or develop resistance, that can ultimately lead to a shorter overall survival. Moreover, the definition of disease progression can vary with individual circumstances and may not capture subtle changes in patient well-being. Another example is a patient with stable but persistent disease may experience significant hardships due to side effects from treatment, resulting in a poor quality of life. In such cases, clinicians are tasked with balancing the goal of maximizing progression-free survival without compromising the patient's overall quality of life or leading them to treatments with little long-term benefit. Looking at the progression-free survival can also lead to incorrect conclusions about drug performance. So the question that needs to be asked is, should a drug be approved that costs thousands or hundreds of thousands of dollars annually if progression-free survival is only a couple months with a corresponding increase in overall survival? And that's the big question. In foreign countries, like in Britain, they don't approve a lot of drugs that we have in the United States because they don't show improved overall survival, but they show improved progression-free survival. And obviously it's debatable. Certain doctors feel one thing, I may feel something differently. But ultimately, at the end of the game, the goal is to find drugs that improve overall survival. So with that, I hope you learned something today listening. Thank you for listening, and I hope you have a great day. And for more information, you can go to my website at www.pladinmds.com. And thank you again.